Well, it is now my pleasure to introduce our opening keynote speaker. He is currently the director and Robert J. Margolis, MD, Professor of Business, Medicine, and Health Policy at the Margolis Center for Health Policy at Duke University. He also devotes his time to many boards and co-chairs several initiatives, and the Alliance is honored that we are among those organizations. He earned his Master of Public Administration and MD from Harvard and his Ph.D. in Economics from the Massachusetts Institute of Technology, and apparently all within like 5 minutes of each other, so we have a lot to learn today. He then developed and implemented major reforms in health policy during his time as Commissioner of the U.S. Food and Drug Administration and later as Administrator of the Centers for Medicare and Medicaid Services. We could think of no one better to provide this State of the Union on the topics of value and innovation. Please join me in welcoming Dr. Mark McClellan.
Thanks, Sarah.
Thank you.
Sarah, thanks very much and good morning. I'd like to thank all of the Alliance team, all of you who came here today. The Alliance has been adding value around understanding complex healthcare issues for many years, so I can do a pun too. It's been a pleasure for me to serve on the board. My other disclosures are listed in my bio, but I do want to cover a range of topics to try to set up some very important discussions today around navigating the frontiers of innovation and value. First off, why the focus on value, and Sarah's already touched on this morning. Then I want to talk about the impact on value-based approaches on payment and healthcare delivery. The way that we pay is changing in this country. It's not happening as fast as some people would like. It's not doing as much on pricing and affordability as some people would like. But I wanted to describe some broad trends that are happening. They're going to continue to happen to change the way that innovation occurs and hopefully advance innovation to improve outcomes and lower costs in our healthcare system. I then want to talk a bit about biomedical innovation, and Mike just touched on this a few minutes ago. There is a big changes happening the way biomedical innovation is occurring. That's had a interaction with the way that FDA gets support for regulating biomedical innovation, and I think there's some opportunities, as you've heard already alluded to today, to change the way that we pay for new treatments and encourage access to patients who really can benefit, and doing it all at a lower cost. But it is important to keep the cost issues in mind as well. So that's what I want to cover, and let me start with a discussion around value itself. There are three main things that the federal government spends money on, and when many people think of value, they think of cost. What can we do to get costs down? That's a great way to improve value if we're spending money on things that really aren't worth the cost. And you can see from this slide how important healthcare programs are. We're spending more at the federal level because of the aging of the population and Social Security, but really the big story for the long term, for the last several decades and for the foreseeable future, is increased spending on healthcare. So with these kinds of budget pressures, it's understandable that we're putting more and more effort into making sure that spending is going into value. But there are other reasons to focus on value besides costs, important and critical as that is. That includes opportunities to improve the way that many of the technologies and much of the knowledge that we have works. Sarah, I think, referred to this as low-hanging fruit. Low-hanging, it doesn't seem to be that easy to get nonetheless. This is a chart describing the opportunities for improving outcomes for cardiovascular disease. It's taken from some work that we've done with the American Heart Association and a range of collaborators on increasing value in healthcare related to cardiovascular disease. There's a lot that we know about how to make modifications and risk factors. These depend on social factors, on influences in people's environment that affect their behavior. Beyond that, we don't do as well as we could on diagnosing common problems. The cardiovascular risk factors like high blood pressure, high cholesterol are among the leading causes, preventable causes of death in the United States, smoking. And often we don't diagnose these problems when they occur. Then there are proven first-line therapies that work for many of these conditions. Patients with high blood pressure and high cholesterol can often be managed on generic drugs, the cost of pennies a day, but we still get compliance rates, adherence rates in the United States for chronic conditions like hypertension and high cholesterol that are around 50% on average. We can do a lot better in many systems that focus on value, but we still have a long way to go. Then there are advanced treatments that we also use, sometimes too much, sometimes too little, often inappropriately, that also create to the value problem. Also failure to provide supportive care near the end of life. So at every step in this process, there are big opportunities for value improvement by really trying to engage patients in their own risk factors and what can be done to overcome those barriers to getting care, which sometimes are financial, often not. If you look ahead to the future, though, I think we're headed for healthcare that may look very different than it does today. Think about the technologies that are in development now. Way more advanced diagnostics that can potentially diagnose cancer off a few drops of blood in the bloodstream. Technologies that make it easier and better to target treatments to particular kinds of health problems, whether it's genetically based cancer treatments or very well targeted nanotechnologies, robotic surgery that builds off of AI to get to much better results, more earlier diagnosis, earlier and more definitive treatment to intercept diseases and even cure them. And then for people who do have consequences of health problems, hopefully a better way to target treatments to them. I just showed you on the previous slide how that's not happening that well now. Treatments that could potentially be targeted to people in their homes, more conveniently using modern technologies that enable telemedicine, remote monitoring, other supports, community-based care that we don't really see today. That's a very different way of looking at the healthcare system than what we're supporting and getting in American healthcare right now. So there are a lot of opportunities for higher value healthcare. People tend to focus on the new cures, the more effective treatments for unmet medical conditions, for finding the people who have them and treating them. Those new treatments often add to costs, not only because they can prevent downstream complications, but especially because they help people and their loved ones live longer and better lives, and that's worth a lot. In addition, though, there are a lot of technologies that can potentially help lower costs, a lot of innovations that are going on today, whether it's using big data to better target interventions to patients who actually would benefit rather than using them broadly, or taking advantage of some of the internet-based and digital technologies that enable people in many different industries to get services that are much more convenient, tailored, right at home the way they want them, instead of the old bricks and mortar institutional approach. Moving to lower cost methods of treatment, like using team-based approaches to care, rather than just relying on traditional doctor visits, support that can be delivered more in the home and much better targeted at what individual patients want. Behind all of that is a need for coordination, for help with integration, but we have the data, the analytics, the models of care for potentially doing that too. And finally, and very importantly, the biggest determinants of the health of individuals in a population are often not the medical factors, but the social factors that influence how they experience care or are not able to really focus on addressing their health needs because of other stresses and risk factors in their lives. And there are many innovations underway today. Companies like CityBlock that are trying to take healthcare right to the biggest risks that individuals are facing, often not medical. The challenge with a lot of these innovations is if you think about the way that business models work in healthcare, the way that we pay for medical services, most of the things on the lower part of this list tend not to get reimbursed very well, if at all. Doctors get paid for office visits. Traditionally, it's been much harder to have community health workers get paid for intervening in why a patient may not make it to a visit or may show up at an emergency room. We pay for visits in the office or in the emergency room. We often don't pay for telemedicine services or remote monitoring that can help prevent the need for those visits in the first place. It's starting to change, but it's been a slow process, and that's why I want to turn to payment. Not because payment determines everything, but if you don't have financing that supports the kind of care that you want, if you don't have alignment, with the kind of innovation that we're seeing in healthcare, it's very hard to make these better models of care, hard to make these innovations sustainable. If you think about the way that many people get care today, it tends to be like on the left side at the top of this chart, care that is about providers and paying providers for specific services, like an office visit or an emergency room visit or a procedure. And if a patient's lucky, they can maybe navigate this whole system themselves. They're facing co-pays typically for every one of those services that I described. It's not care that's centered on the patient, it's care that's centered on the services, on the providers. Think about a different model of care, which is where a lot of the efforts in value-based care and value-based payment reform are headed, on the right side of the chart, which is really about care integration for a patient, bringing together the particular kinds of primary care services, the old style office visits, plus the new ways, innovative ways of delivering medical services, the specialty care, the drugs and devices, and very importantly, the social services and support that enable that patient to get the best outcome for the resources that are available. Most people today in the United States don't have that experience with care, but there are lots of efforts underway around the country to try to move to that, towards care that is about people, not about services and providers. One framework for thinking about these payment reforms has been developed by the Healthcare Payment Learning and Action Network, which I've had the privilege of co-chairing. It's a public-private effort supported by CMS and with participants from all stakeholder groups throughout the healthcare system to try to find ways to move more quickly and effectively into new payment models. Again, not because we care about the payment models in themselves, but because we want to sustain and grow these innovative models of care that target all of these different innovations to the people who can most benefit, that innovate around them. You can think of 4 categories here. The slides, I think, are available online if you want to look at the details or go to the website. Traditionally, we've paid for fee-for-service. In the 90s and 2000s, and even today, we've tried a lot of what the land calls Category 2 fee-for-service with a bit of a bonus or a penalty for following some kind of process of care, or maybe adopting an electronic health record. These are maybe important steps, but this idea of incentivizing doctors or incentivizing healthcare providers or even incentivizing patients doesn't really get at alignment. The Category 3 and 4 models here are really about setting up payments that are about people, maybe a little bit like, say, accountable care organizations with shared savings, or a lot, like episode payments for a whole condition, or direct contracting for primary care with links to accountability for actually getting better results for people. That's the shift I'm talking about, from paying for services to paying for people. And it's those Category 3 and 4 models that seem to hold the most promise, especially when we get away from fee-for-service, for actually getting total costs of care down for patients and improving their outcomes. The thing is, we're not really that far away from fee-for-service yet, despite all the talk of value-based payment reform. This is from the most recent LAND survey. 39% of patients' payments overall in this country are estimated to be in Category 1. 25% in that Category 2, which is still fee-for-service, so still very hard to pay for things like social services or other interventions that are innovative and work for certain kinds of patients, but may not work for all and aren't covered under traditional fee-for-service models. Category 3 begins to do that, but most of what we've implemented in payment reform so far, what are called shared savings models, where there's a little bit more payment if overall costs for patients come down while improving important measures of outcomes, but it's still largely a fee-for-service based system. Again, the better results have come in Category 3B here. That's that 9.4% on the right side of the chart, with upside and downside risk. It's not about risk, it's about making the payments about the people and giving some flexibility and accountability to the healthcare providers involved to deliver them together in integrated care, or Category 4 models, which are even farther away from fee-for-service. We're still at only about $1 in $6 spent in this healthcare system overall in those models, and healthcare organizations that have gone further in this direction, whether they're delivering specialized care or integrated care like ACOs, they've gotten better results, but again, that's still a minority. Most of these bigger reforms have happened in the Medicare Advantage program and to a growing extent in the traditional Medicare program, but again, we're still really in the early days of implementing these more substantial payment reforms. This is a chart from the Learning and Action Network's recent goals, which Secretary Azar endorsed. This is an effort that builds on previous payment reform activities in the Obama administration, with the idea of pushing over the next 5 years much further into payment models that are aligned with the kind of person-centered care that innovation promises to reward. So we are still in the midst of this kind of transition in places like North Carolina, where there have been commitments across the board, public and private sector, to move faster in these reform areas. There's a chance that we could get to these kinds of big changes in reform over the next 5 years. And this means things like medical home payments, primary care that's integrated in the community around a person. It means specialized care services that are not just a bunch of add-ons and out-of-network extra bills for emergency services, but overall coordinated care for specialized care needs for patients, a care integrator that can put all of these different kinds of care reforms together for a patient, and as you heard from Mike, maybe some steps in the direction of paying for drugs and medical products in a way that reinforces their benefits for individual patients. I just want to spend a few minutes on biomedical innovation, since that's a key part of the issues that people think about when they're thinking about innovation. As I've already talked about, that's not all, but it is an important part. And the face of innovation is changing. As I mentioned earlier, we're seeing more abilities to target treatments to unmet needs for individual types of patients with more confidence, thanks to advanced genomics, proteomics, thanks to gene therapies and other kinds of targeted therapies and combination therapies, increasingly backed by big data, AI, etc. The right combination of treatments for each individual patient, we're getting better at doing. We've still got a ways to go, but there's a lot going on in biomedical innovation. And this has been supported by some very important bipartisan policies. Legislation like the 21st Century Cures Act created a lot more support both at the FDA and in public-private collaborations to develop better evidence, to validate more efficient ways of showing that treatments are safe and effective, and to learn more about those treatments from a safety and effectiveness standpoint once they get on the market. That's also been reinforced by user fees that FDA receives in order to meet expectations about having scientific capabilities and being able to handle these kinds of new emerging technologies in a quick and efficient way. That's been reflected, again, I won't go through the details here, in a significant increase in the number of drugs approved, and particularly the number of drugs approved that are addressed towards unmet medical needs and have the potential for changing lives for patients. The same thing goes for medical devices, where there are now breakthrough approaches for medical devices, ways to develop more evidence on devices that have reached the market, where there's still often questions about how well they work in particular settings, and often expectations that these devices and the way they're applied can get better over time. Those are all good steps to encourage. But we haven't seen those kinds of changes yet on the access, coverage, and payment side for medical technologies, biomedical technologies to keep up. And so we're seeing, as more of these treatments reach the market, a challenge that value-based approaches, I think, could really help address. Take some of the new gene gene therapies or other transformative therapies. They've raised concerns about high upfront costs that have an impact on budgets, especially for state programs like Medicaid. Many of these programs are approved because they're safe and effective, but there's still questions about how they'll work downstream in patients, their long-term benefits for particular kinds of patients, and whether they can get better over time. Technologies like CAR-T were approved for very good reasons. They transform lives in many patients, but the studies that led to approval only applied to a small number, say, of Medicare beneficiaries, and did not fully study a lot of different potential indications for the technologies. Those are questions that, while they don't really get to safety and effectiveness, are very important for determining what's the best way to use a technology in particular patients. And so it really goes to the issue of needing a lot more evidence, not for safety and effectiveness purposes, but if we're heading into an era of personalized medicine that's aiming to get real value for individual patients, the need for doing a much better job of getting information on comparative effectiveness, comparative cost effectiveness, that doctors and patients who are moving into these accountable care systems, ones that focus on best results for individual patients at the lowest cost, they need much more of that kind of evidence. And that's why I think we're seeing a rising interest in approaches like value-based payment for drugs and devices. Some of these value-based payment approaches involve health technology assessments, looking at all the evidence that we have and trying as best we can to apply it to particular kinds of patients. That's done in other countries. It's done in the U.S. in Medicare Advantage plans and in commercial plans and Part D plans, et cetera. But beyond that, where we don't have all the answers at the time of approval, thinking about outcomes-based contracts that encourage more development of evidence for particular kinds of patients in real-world settings after approval can help. We've also seen models start to emerge of moving away for paying on a volume basis. That's what I talked about earlier, not paying for the volumes of drugs sold, but maybe paying for their impact in a population. We're living in an era where we can actually think about eradicating diseases like hepatitis C and HIV. It's going to be very hard to get there under the traditional volume-based payment methods, both for the drugs and for the providers who need to be involved in finding every single case and making sure we're getting the right treatments to each patient. So these kinds of models, I think, are going to be increasingly important for the innovations in biomedicine that are coming, where they may have big long-term effects, but those may differ across different kinds of patients, where the technologies may and how we apply them may improve over time, especially if we're learning more about them, and where there's an opportunity to align payments for new biomedical innovations with those changes in payments that are happening to get more value to individual patients on the provider side. So those are some of the advantages of moving to value-based payments. There are some real challenges here. We don't have the infrastructure we need. Like I said, we've built a lot of infrastructure to support drug development and get products approved that are safe and effective. We've got a ways to go in getting the evidence that doctors and patients need to use these technologies and other cost-saving interventions as effectively as possible in that kind of personalized, very prevention-oriented, home-based, person-centered healthcare system that our innovations collectively should be able to deliver. There are regulatory barriers to getting there, since lots of our regulations are set up based on a volume-based payment system, not on trying to promote value, and we've got limited experience with these models. So my hope is that as we keep thinking about real-world evidence and these other supports for moving to a value-based system during the course of the day, we'll be able to take some further steps this morning towards getting to a high-value healthcare system. The potential is tremendous, and I really appreciate all the diverse perspectives that are coming together here today to talk about where we are and how we can move these goals forward. Thank you very much for the opportunity to kick off today's discussion. It's been a pleasure to talk with you.